Imagine walking into a patient's room on the wards, right? The patient is sitting up, talking to you, totally lucid. They have a modern left ventricular assist device whirring away in their chest. You reach out, put your fingers on their wrist to check their vitals, and there is absolutely no pulse.
Yeah, none at all.
Not faint, just completely absent. It trips up medical students and residents every single time they first encounter it. I'm Dr. Griffin.
And I'm Dr. Taylor.
Welcome to the Evidence of the Bedside Rapid Review series. Today's Rapid Review is a 50-question high-yield sprint designed specifically for internal medicine residents preparing for the ITE and clinicians studying for the IBIM board exam.
If you are with us right now, you are probably on the wards or cramming for boards. So I want to address you directly. Please subscribe, like, and share this rapid review with colleagues who are in the middle of board prep. We are going to cover a massive amount of ground very quickly. But we aren't just going to read off flashcards, you know. We are focusing heavily on the underlying mechanism so you actually remember the material when you sit down for the exam.
Right. So we'll be pimping each other back and forth, rapid-fire style, going through exactly what you need to know. I'll kick us off with the foundational classifications. What is the exact ejection fraction cutoff for HFrEF?
40% or less. The underlying clinical logic here is that this cutoff represents primarily systolic dysfunction. Mechanistically, the ventricle simply cannot contract effectively enough to eject a normal stroke volume.
So forward flow is severely compromised.
Exactly. What defines HFpEF?
That is an ejection fraction of 50% or greater.
Yeah.
And if you need a mental model for the boards, think of HFrEF like a weak, overstretched balloon that just can't squeeze.
Oh, I like that.
Yeah. And HFpEF, on the other hand, is like a stiff leather pouch. It squeezes just fine, but the muscular walls are so rigid and thick that it cannot properly relax and fill with blood during diastole. So what is the most common underlying cause of that stiff leather pouch?
Hypertension. It's a pure mechanical consequence. Chronically elevated systemic pressure forces the left ventricle to pump against a massive afterload. Over time, that constant resistance inherently causes the myocardium to hypertrophy and stiffen, ruining its compliance. So how do we classify a symptomatic patient with an ejection fraction hovering in that, that gray zone between 40 and 50%?
That intermediate zone is categorized as heart failure with mildly reduced ejection fraction.
Yeah.
And from a clinical management standpoint, it is treated very similarly to HFrEF.
Yeah, focusing on those same foundational mortality-reducing therapies.
Exactly, which we'll discuss shortly.
Let's
shift our focus to the initial labs we draw when a dyspneic patient hits the emergency department. What BMP level typically rules out heart failure?
A level less than 100 picograms per milliliter. The reason this is highly testable is that it carries a massive 90 to 97% negative predictive value.
Wow.
Yeah, if it's under 100, the stretch on the ventricles is minimal. This is a board favorite because in a busy ER, distinguishing heart failure from a COPD exacerbation or pneumonia is critical.
Right, a low BNP essentially points your workup away from the heart.
Exactly. What about for NT-proBNP? What is the standard rule-out threshold?
Less than 300 picograms per milliliter makes heart failure very unlikely. It's important to memorize both thresholds because, well, different hospitals use different standard assays.
Sure.
But here's a clinical scenario that always frustrated me on the wards. You have a patient with a high body mass index who is clearly in volume overload, yet their BNP comes back totally normal. What surprising effect does an elevated BMI have on BNP levels?
It artificially lowers them?
Yeah.
Which is completely counterintuitive when you are staring at an edematous patient in respiratory distress.
Right.
The mechanism here is that adipose tissue actually increases the clearance of natriuretic peptides from the bloodstream. So in patients with obesity, those fat cells are essentially acting as a sponge.
Just clearing the peptide.
Exactly. Clearing the peptide and falsely lowering the lab value, completely masking their true filling pressures. You have to suspect it clinically. Conversely, name a guideline-directed medication class that artificially elevates BNP.
The ARNIs, like sacubitril/valsartan. And the mechanism is direct. Neprilysin is the enzyme that naturally breaks down BNP.
Right.
Because an RNE specifically inhibits neprilysin, it directly stops that physiological breakdown. So you absolutely cannot rely on a standard BNP lab to track volume status once an RNE is initiated.
You have to use NT-proBNP instead.
Spot on. Let's move to imaging. What is the primary first-line diagnostic imaging modality for suspected heart failure?
Echocardiography. It is entirely non-invasive and gives you the structural blueprint you need to guide therapy. You get chamber size, wall thickness, systolic and diastolic function, and any regional wall motion abnormalities that might hint at underlying ischemia or CAD.
Absolutely.
When is a cardiac MRI indicated in routine heart failure evaluation?
Well, it is not routinely indicated. You only reach for the cardiac MRI if your echo images are technically poor, maybe due to severe lung disease or body habitus, or if you specifically suspect an infiltrative process like cardiac amyloidosis or sarcoidosis.
Where you need to see tissue characterization and late gadolinium enhancement.
All right, we are moving from diagnosis to the foundational outpatient management of HFrEF. What are the 4 pillars of mortality-reducing guideline-directed medical therapy for HFrEF?
An RNA, a beta blocker, an MRA, and an SGLT2 inhibitor. I always compare these to the 4 load-bearing walls of a house.
That's a great way to look at it.
Yeah, in the past we used to titrate one drug to the maximum dose before adding the next. Now the guidelines emphasize initiating all 4 pillars simultaneously at low doses because the mortality benefits are additive and independent.
You need all 4 walls put up as quickly and safely as possible to prevent the failing heart from collapsing.
Exactly. When transitioning a patient from an ACE inhibitor to an ARNI like valsartan sacubitril, what is the mandatory washout period?
36 hours, strictly. And the rationale here is literally life and death. Both ACE and neprilysin break down bradygana.
Right.
Overlapping an ACE inhibitor with an ARNI blocks both degradation pathways simultaneously, causing bradykinin levels to skyrocket.
Which massively increases the risk of sudden life-threatening angioedema. You just have to wait for the ACE to clear.
Absolutely.
Yeah.
Which 3 beta blockers have a proven mortality benefit in HFrEF?
You only have 3 options here: metoprolol succinate, carvedilol, and bisoprolol. It is incredibly important to remember this is not a class effect.
Right.
Do not use just any beta blocker like atenolol or metoprolol tartrate because they do not have the large randomized trial data backing up a mortality benefit in this specific population. In what clinical scenario should you avoid initiating a beta blocker?
During acute decompensated heart failure, because of their negative inotropic effects, blunting contractility will drastically exacerbate acute volume overload.
And potentially plunge wet patient into cardiogenic shock.
Exactly. You always wait until they're euvolemic before starting or up-titrating their beta blocker.
What is the exact eGFR cutoff for initiating an MRA like spironolactone?
30 milliliters per minute. And just to clarify why this is such a hard stop on the boards, and in practice, advanced kidney disease vastly increases the risk of fatal hyperkalemia when you block aldosterone.
Right, because aldosterone's whole job is to dump potassium into the urine.
Exactly. The kidneys simply cannot excrete the potassium load without adequate filtration, leading to deadly arrhythmias. Do SGLT2 inhibitors require a patient to have type 2 diabetes to be effective in HFrEF? Absolutely not. They reduce worsening heart failure and cardiovascular death, regardless of the patient's diabetes status.
Which is still wild to think about.
It is. The mechanism of action goes far beyond simple urinary glucose excretion. They alter myocardial metabolism, reduce preload through osmotic diuresis, and essentially shift the failing heart to a much more efficient metabolic engine.
What is the eGFR cutoff for using dapagliflozin in heart failure?
30 milliliters per minute. Below that, the kidneys can't filter enough for the drug to adequately exert its metabolic and osmotic effects at the tubule. However, it's worth noting that empagliflozin goes down to an eGFR of 20 milliliters per minute.
Good distinction.
For Black patients with NYHA class 3 or 4 symptoms who are already on optimal therapy, what addition improves survival?
Isosorbide denitrate hydrolysine. The mechanism provides a brilliant combination of preload reduction through venodilation and afterload reduction through arterial dilation.
I will note that the race-based nature of this specific guideline is currently being heavily scrutinized in the medical community, but we are simply reporting the current guideline text you will be tested on. Does digoxin provide a mortality benefit in HFrEF?
No, it does not.
Right.
It is purely a symptom management tool. It only reduces heart failure hospitalizations and assists with rate control if the patient happens to have concomitant atrial fibrillation.
But it doesn't make them live longer.
Exactly, which is why it's a second-line agent.
What is the exact clinical indication for adding alvelbardine?
It is for HFrEF patients who are in sinus rhythm but still have a resting heart rate of 70 or higher despite being on maximally tolerated beta blockade. Ivabradine specifically inhibits the funny current in the SA node to prolong diastolic filling time, but it only works if the SA node is driving the rhythm, which is why they absolutely must be in sinus rhythm. Which class of calcium channel blockers is strictly contraindicated in HFrEF?
The non-dihydropyridines.
Yeah.
Specifically drugs like verapamil and diltiazem.
Yeah. They have dangerous negative inotropic effects that will depress a failing weak ventricle even further, potentially throwing the patient into acute decompensation. Should statins be initiated solely to treat heart failure?
No. Large randomized trials show absolutely no benefit in adding statins to reduce heart failure mortality unless the patient have another accepted indication.
Like established CAD or severe hyperlipidemia.
Exactly. Statin therapy doesn't fix the underlying muscle weakness. What is the current stance on intravenous iron therapy in HFrEF?
It can definitely improve functional capacity and quality of life in patients with documented iron deficiency, helping their muscles utilize oxygen much more efficiently.
But no mortality benefit?
Right. Recent data confirms it makes no difference in actual cardiovascular mortality or heart hospitalizations. It's about symptom burden, not survival.
All right, let's assume medical therapy is maximized. The next step in the clinical algorithm is assessing device indications. What is the ejection fraction threshold for an ICD for primary prevention?
35% or less, specifically in patients who still have NYHA class 2 or 3 symptoms while on optimal, maximally tolerated medical therapy. The device is there to abort lethal ventricular arrhythmias. How long must you wait to place an ICD after an acute myocardial infarction?
At least 40 days. The rationale here is to allow adequate time for potential myocardial recovery. The stunned myocardium might heal, and the ejection fraction could improve back above the 35% threshold on its own.
Eliminating the need for a permanent invasive device.
Exactly. For non-ischemic cardiomyopathy, what is the ICD waiting period after initiating medical therapy?
3 months. Again, the goal is to give your guideline-directed medical therapy, those 4 load-bearing walls we talked about, time to reverse remodel the heart. You want to see if the ejection fraction improves beyond that 35% threshold on medications alone.
Makes total sense.
Which specific patients receive the maximum benefit from cardiac resynchronization therapy, or CRT?
Those with an ejection fraction of 35% or less, who are in sinus rhythm, and who have a left bundle branch block, or LBBB, with a QRS duration of 150 milliseconds or longer. How exactly does CRT help these specific patients?
Biventricular pacing restores electrical synchrony. When you have a wide LBB, the ventricular walls contract at completely different times, wasting huge amounts of kinetic energy.
Right.
CRT paces both ventricles simultaneously, so they squeeze together as a cohesive unit.
Exactly. I like to think of a left bundle branch block as a boat full of rowers completely out of sync with each other.
I love that analogy.
Yeah. One side is pulling, then the other side pulls. They're exhausting themselves, splashing water everywhere, but going nowhere fast. The CRT device acts as the coxswain at the back of the boat, calling the cadence and getting both ventricles pulling together at the exact same time again to maximize forward stroke volume.
That beautifully leads us into the distinct clinical challenges of diastolic dysfunction. What is the primary medical management strategy for HFpEF?
It historically revolves around meticulous symptom control, using diuretics for volume overload, and aggressive antihypertensives targeting a systolic blood pressure strictly under 130.
Right, to reduce the massive afterload that the stiff ventricle has to pump against.
Exactly. Which medication class recently received a Class 2A recommendation for HFpEF?
SGLT2 inhibitors. This was a massive paradigm shift in cardiology. They have been shown to effectively decrease heart failure hospitalizations and cardiovascular mortality in this specific group.
Marking one of the first times we've had a truly modifying therapy for the stiff ventricle.
Yes. When might an MRA be considered in HFpEF?
In select patients who have an elevated BNP or who have had a heart failure hospitalization within the past year. But I'm going to note a huge clinical caveat here. The data from the TAPI-HA trial had major regional variations. Yet, the benefit was mostly seen in the Americas and not confirmed in Eastern Europe, likely due to differences in patient adherence and diagnosis. So this is a nuanced clinical decision, not a blanket rule for every single HFpEF patient. Emerging data supports which drug class for patients with HFpEF and obesity.
GLP-1 agonists, like semaglutide, they induce substantial weight loss, which mechanically unloads the heart, decreases systemic inflammation, and drastically improves the patient's functional capacity and quality of life scores.
Okay, we are transitioning now from outpatient chronic management to the inpatient management of acute exacerbations. What is the recommended diuretic dosing strategy for a patient presenting with acute volume overload?
You need high-dose intravenous loop diuretics, Specifically, the initial IV dose should be 2.5 times their outpatient oral daily dose.
Wait, really? 2.5 times?
2.5 times. This makes perfect sense mechanically if you think about it. I always liken it to wringing out a saturated sponge. A light, gentle squeeze does absolutely nothing when the sponge is that soaked. You need a heavy, aggressive initial squeeze to overcome the severe vascular congestion.
Right. Break the nephron's intense sodium avidity and actually force the fluid out of the body.
Precisely. If a patient develops cardiorenal syndrome during this aggressive diuresis, what medication should be withheld?
ACE inhibitors, ARNIs, and MRAs should be paused temporarily. It's a delicate balancing act. You are intentionally creating a state of mild intravascular depletion to pull fluid from the tissues.
So you have to remove the drugs that lower glomerular filtration pressure.
Right, to protect the kidneys while you decongest the venous system. Does administering low-dose dopamine improve diuresis in acute decompensated heart failure?
No. Despite historical practices suggesting a so-called renal dose of dopamine, large randomized trials definitively show it offers absolutely no benefit in preserving kidney function or increasing urine output.
So it is an outdated practice you should not select on the boards.
Correct. What hemodynamic parameters define cardiogenic shock in these patients?
It's strictly defined by a low cardiac output with a systolic blood pressure under 90, accompanied by clinical signs of end organ hypoperfusion.
Right.
You are looking for altered mentation, cool and mottled extremities, or an elevated serum lactate indicating dangerous anaerobic metabolism. When is invasive hemodynamic monitoring, like a Swan-Ganz catheter, indicated?
In patients presenting with uncertain hemodynamics, or those who suffer worsening kidney function despite receiving what should be appropriate medical therapy.
You need the pulmonary artery catheter to see their true filling pressures and cardiac index.
Exactly, to guide your inotropic support or diuresis accurately. After an acute admission, how quickly should a patient be seen in the clinic?
Within 7 days. The physiological shifts that happen when a patient transitions from IV to oral diuretics at home are massive. Early follow-up to definitively assess euvolemia and restart any pause guideline-directed therapies dramatically reduces the risk of a 30-day readmission.
That makes perfect sense.
Yeah. Well, comorbidity is heavily underdiagnosed in heart failure and actually requires a formal sleep assessment.
Sleep-disordered breathing. Treating obstructive sleep apnea with continuous positive airway pressure, or CPAP, significantly reduces the apnea-hypopnea index, decreases nocturnal afterload, and improves cardiovascular hemodynamics.
But what specific sleep apnea treatment is strictly contraindicated in patients with an ejection fraction less than 45%?
Adaptive servoventilation used for central sleep apnea. In the HFrEF trial, it was shown to actually increase cardiovascular mortality in this specific heart failure population, making it an absolute contraindication on the boards and in practice.
Wow, good to know.
Let's step away from typical heart failure for a second and look at the weird stuff. A patient comes in after a massive stressor and their apex is ballooning on the echo. What condition features apical ballooning and typically follows a severe stressor?
Cardiomyopathy. It mimics acute coronary syndrome perfectly on an ECG with ST elevations and positive troponins, but functionally spares the basal wall motion.
And it is vital to clarify that the trigger doesn't have to be negative emotional stress.
Right. Intense physical stressors, severe illness, or even a surprise birthday party can trigger the massive catecholamine surge that stuns the myocardium at the apex. How is giant cell myocarditis definitively diagnosed?
Endomyocardial biopsy. It is a rapidly progressive and highly fatal condition characterized by multinucleated giant cells destroying the myocardium. It requires extremely prompt immunosuppression and often mechanical circulatory support.
So you cannot delay the biopsy.
Exactly. If a young, otherwise healthy patient comes in with fulminant heart failure and heart block, this should be at the top of your differential.
Got it.
If you suspect cardiac sarcoidosis but want to avoid an invasive biopsy, what imaging can confirm it?
A cardiac MRI showing patchy lead gadolinium enhancement, or a PET scan showing focal uptake in the myocardium, combined with a known extracardiac sarcoid diagnosis. What burden of premature ventricular contractions is required to trigger a tachycardia-mediated cardiomyopathy?
More than 10,000 PVCs per day, or more than 10% of all total beats on a Holter monitor. This constant desynchrony weakens the muscle over time.
But the excellent news here is that catheter ablation is often completely curative and dramatically reverses the heart failure.
Yeah, that's incredibly rewarding.
Finally, let's cover the ultimate escalation of care for end-stage heart failure. What is the primary indication for a left ventricular assist device, or LVAD?
An ejection fraction less than 25%, accompanied by severe NYHA class 3 or 4 symptoms, despite maximal medical therapy.
Right.
It is used either as a temporary bridge to transplant or as a permanent destination therapy for patients who are not transplant candidates. What is a physical exam quirk of patients with a modern LVAD?
As we mentioned at the very top of the show, they completely lack a palpable pulse. Because these continuous flow devices use an impeller to push blood continuously rather than in discrete pulsatile beats, you cannot use a normal automated cuff or feel a radial pulse.
Right, their mean arterial pressure must be measured manually by placing a Doppler over the brachial artery.
Exactly. What specific gastrointestinal complication is highly associated with those continuous flow LVADs?
GI bleeding. It occurs in nearly 25% of patients, and it typically stems from newly formed small bowel arteriovenous malformations, or AVMs.
The continuous flow creates an acquired von Willebrand syndrome, breaking down clotting factors and leading to these severe mucosal bleeds.
Yep. Which infectious agent requires routine prophylaxis in moderate to high-risk cardiac transplant recipients?
Cytomegalovirus, or CMV. Because these post-transplant patients are profoundly immunosuppressed to prevent graft loss, they are highly susceptible to opportunistic viral infections.
When is the incidence of allograft rejection the highest after a heart transplant?
Within the first 6 months. That is exactly why they require routine surveillance and myocardial biopsies during that high-risk window to catch cellular or antibody-mediated rejection before the graft fails. Name a major post-transplant drug interaction involving the immunosuppressants, cyclosporine, and tacrolimus.
Both are heavily metabolized by the hepatic cytochrome P450-3A4 system, meaning if you administer common cardiac medications that act as inhibitors like diltiazem or verapamil, you will drastically decrease the clearance of the immunosuppressants.
This causes their blood levels to spike, leading to severe nephrotoxicity and immunosuppressant toxicity. That's our rapid-fire review for today.
Before you put your notes away, think back to that metaphor of the week, overstretched balloon versus the stiff leather pouch. As our diagnostic tools get sharper, think molecular profiling, continuous hemodynamics, and targeted therapies, we are realizing those two broad categories might actually be hiding dozens of distinct microphenotypes. Will the 4 pillars of therapy eventually become completely custom-tailored genetic blueprints? Something for you to mull over as you digest this material. Make sure you subscribe, like, and share this rapid review with your team. See you at the bedside.